So, hey everyone, my name is Dr. Jocelyn Kressler. I am a clinical psychologist working at the Road Home program. I specialize in trauma and addiction. So, if you have any questions about either of those things, be it today or in the future, feel free to shoot me an email. Today, we're going to be talking about military sexual trauma. Not only understanding what military sexual trauma is in and of itself, but also in understanding different ways to work with survivors of military sexual trauma. And so I'm specifically going to be gearing that towards medical providers, as I know a large number of individuals that kind of view these didactics are medical providers. If you do have any questions, as I said before, feel free to unmute yourself and ask. I'm happy to take them as we go. And if you have any questions at the end or things we didn't get to, any questions in the future, I have my email at the bottom. I should also have it on the last slide as well. So feel free to reach out to me. All right, so cool. So before we even talk about military sexual trauma, or MST as I'll be referring to it as, let's talk a bit about military culture. So military culture is much different than any other kind of career because the demands of the military life really do create a unique set of pressures, even a unique structure of life on both service members and on their families. And so for most civilians in the civilian world, your job is kind of what you do, whereas in the military, your occupation is who you are. It is essentially your identity. And so the military culture essentially has its own community with clearly defined rules and expectations, some of which are applicable in the civilian world and many of which are not. So we have 6 branches, and the 6th one, Space Force, was just introduced at the end of 2019. So we've got the Coast Guards, who are part of the Department of Homeland Security, and then everyone else is part of the DoD, the Department of Defense. So we've got the Space Force, the Army, the Air Force, the Navy, and the Marines. And then also kind of what they're typically called, right? So soldiers are, for example, soldiers are only actually Army, members of the Army. So not everyone is a soldier, just individuals in the Army. But a good generic term when you're working with an individual that's currently in the military is a service member. And that can refer to someone that's active duty, so currently, or also someone that's in the reserves. For someone that's no longer in the military, but has a history of being in the military, that's where that term veteran kind of might be a more appropriate term to use. So there are some distinctions, right, between these different forces in their missions. So I wanted to just give a little bit of information about that. The Army really is focused on land operations. The Navy has to do more, of course, with water and tactical operations. The Air Force, right, we have the airlift and tactical air combat. The Space Force has to do with protecting US and allied interests in space and also space capacities. The Marines are part of or connected in some part to the Navy, but they're considered more of like the rapid deployment force. And then we have the Coast Guards, who are the individuals that safeguard the maritime interests and tend to do most protection during times of peace and in between different, So some of the terms that you might hear when veterans talk or active duty service members, you might hear OEI or OIF, OEF, OND, and these just refer to different current wars that are going on. So OEF is Operation Enduring Freedom, which is located in Afghanistan. OIF is Operation Iraqi Freedom in Iraq. Operation New Dawn is like the next step of OIF. So it continues in Iraq, but just technically OIF began in September of 2010. GWOT is the Global War on Terror, a post 9/11 vet. So that's a veteran or a service member that started their military service after the terrorist attacks of 9/11, 2001, and then Operation United Assistance. So a couple common myths about military veterans to just kind of throw out there is it's often thought that if you're a veteran, then you definitely have some sort of psychological disorder. This is actually not true at all. Most veterans actually do not experience psychological disorders after coming back from their service, whether it's combat or not. A smaller percentage, maybe 10% actually do. But because those are the individuals we tend to see, it might seem like those are the only veterans. Also, that all veterans are brainwashed, right? This is a common myth. There are certain standards and procedures that are kind of instilled into veterans in order to be able to respond effectively in times of crisis and life or death situations. But brainwash is probably not the most accurate phrasing for that. And the other one is that veterans joined the military because college was not an option, either financially or academically. The military does provide pretty great benefits for individuals that have served. That said, many veterans will tell you that they engaged in service for a wide variety of reasons. Some might be financial, some might be academic, but there's a whole host more. The number one thing that I encourage everyone, if you don't already know it, if you see a veteran or a service member or you meet them, very much discourage you from asking them whether they've killed anybody. This is actually a common thing that people ask, especially civilians. And oftentimes it's not coming from a place of disrespect, it's more a place of naivety. But this is a question that many veterans will say they've been told, and it's distressing for them to hear that. It's inconsiderate, it's disrespectful, not intentionally so, but that was just something, if you don't already know it, strongly encourage or discourage that. So let's talk a bit about military sexual trauma. So according to the APA and the VA, or the American Psychological Association and the Veteran Affairs, military sexual trauma is considered a psychological trauma that has resulted from a physical assault of a sexual nature, a battery of a sexual nature, or sexual harassment, which occurred while the individual was serving on active duty for training, or inactive duty training. So what that means is from the moment an individual signs papers to be in the military, to the point that they are discharged, including whether they're deployed or not, whether they're on break between deployments, any sort, whether it occurs on base, off base, whether they travel with their family, but they're still in the military. If sexual violence occurs to them during any of this, it's considered military sexual trauma. The other thing to highlight is that oftentimes when we think of military sexual trauma, we think of direct penetration and rape. When in reality, military sexual trauma actually spans a greater range than that. It also involves sexual harassment. So it's any unwanted sexual attention that might happen during military service. And sexual harassment, in this context is further defined as kind of this repeated unsolicited verbal or physical contact from an individual or in a situation that is threatening. And so it's been found in 2016 that 16% of veterans and service members have experienced military sexual trauma. 3.9% of those are men and 38% of those are women. Here's the thing. These numbers are very underreported, extremely underreported. So these are 16% of individuals of those that have actually felt comfortable reporting it. Many more don't feel comfortable, of which we'll talk about in a little bit. The other thing to note is that 3.9% of men and 38.4% of women have experienced military sexual trauma. There are many more men in the military than there are women. So even though 38% of women have experienced MST, 3.9% of men is actually equates to a greater number than the 38.4% of women. So what does MST include? Like what might be considered MST? Just kind of getting a little bit more information. So it might include someone that was physically forced into participation of some unwanted sexual nature. Perhaps they were unable to consent to sexual activities. Perhaps they were pressured or coerced or threatened into sexual activities. It could even be an individual that initially did consent, initially was interested, and then at some point no longer wanted to consent, or at some point felt that things became coerced or threatened or pressured. And that's a really big thing with veterans that I've worked with, where if they were flirting with someone or they were having alcoholic beverages, perhaps at the beginning they were interested in this individual, and at some point things changed, but because they were originally interested, they don't necessarily consider it MST when really it is. And this is not, and that explanation is not just for military sexual trauma, that's for all sexual violence. So MST can involve things such as threatening, offensive remarks about a person's body or sexual activities, catcalling, for example, unwelcome or unwanted sexual advances, unwanted touching or grabbing. And then it can also include kind of more black and white sort of things that we might think of when we think of sexual trauma: oral sex, anal sex, sexual penetration with an object, or sexual intercourse. So there is a spectrum of behaviors. Going down would be helpful. Okay, so let's talk a little bit about prevalence and reporting, right? So 1 in 4 women screen positive for MST, 1 in 100 men screen positive for MST. But again, these are the individuals that felt comfortable reporting. And again, just because it's 1 in 100 men, the number of men in the military are much larger. So that number is much larger than the 25% of women. So let's see. The other thing that I want to highlight, because I don't want to read this entire PowerPoint to you, we're recording it. I'm happy to hand this out. So really it's more for discussion. But one big thing that I really want to highlight is that it's estimated that 66% of incidents related to military sexual trauma are not formally reported. So these numbers are really the 34% that we have any information about, and there is 66% of individuals that aren't saying anything for various reasons that we'll talk about. But I just kind of want to hit that idea home. And that's why it's really important for us to, as providers in whatever field, to be sensitive to individuals that might have experienced trauma and to be informed and aware so we can provide that care. So what are some of the reasons that survivors might not report? Yeah, please.
Do you think the numbers from the previous page, those like 66% unreported, do you think those are comparable to outside of the military as they are within military, or do we just not know?
Yeah, so the statistics are a bit different. Um, the reporting among survivors of sexual violence in the civilian world is going to be higher than in the military world because of the culture. That said, I would say probably within 10%. My understanding, I don't have the statistic offhand, but my understanding is that we only know about 40% of individuals that are reporting. So 40% of individuals in the civilian world that experience sexual violence are reporting, or up to 40%, and like 60% are not. So they're pretty comparable. I do not have the exact number for you though, unfortunately.
Thank you.
Yeah, of course. And thanks for asking. Okay, so what are some of the reasons that people don't feel comfortable reporting? So sometimes it's concerns about further victimization by their offender, especially if you're working or living in the same quarters as someone that has harmed you. It's going to be really uncomfortable or tricky to want to report. They might also fear kind of retribution. What might occur? What may be the consequences if they do? Sometimes they are fearful that they won't be believed or accused that it's their fault, that they did something to bring it on, um, or they weren't clear, um, or fear that it might end their military career, or they might be changed and transferred to a different unit. Um, for for men, because sexual violence is not just about women at all, as we were talking about. But as it relates to men, there's a lot of fear of being accused of, um, if for men that identify as heterosexual, of being accused as identifying as queer or homosexual or bisexual, um, and concerns about kind of how that kind of sits with them. Um, Also being ostracized, right, from your coworkers. If you're reporting, if you report someone that's in your unit, right, and they get removed or they get in trouble, it is not uncommon for people to be ostracized from the rest of the group. They might even fear kind of the shame or stigma associated with others potentially learning about it or having to talk about it, whether officially or having to repeat their story to different individuals as you go up the ranks to report this, or having to potentially repeat this story in the criminal justice system on trial, um, or even if you're trying to get service connection. Um, one of the other things that I hear a lot is that there's fear that nothing will happen as a result of speaking up. What's the point? And that's a really big one that I hear um, from survivors of all gender identity, sexual orientations, all intersections of diversity. So MST and cumulative trauma. So combat exposure actually increases the risk for military sexual trauma among female identified veterans that are deployed to Afghanistan and Iraq. Um, and MST has also been found to be associated with higher rates of childhood physical and sexual assault and sexual assault outside of the service. The other thing that's important to kind of recognize is that some research has been found that MST compared to other forms of trauma might lead to more severe PTSD in comparison. So let's talk a little bit about MST, gender identity, and sexual identity or sexual orientation. Right, so the experience of sexual violence, be it military sexual trauma or otherwise, can really kind of create challenges, internal challenges, but also interpersonal challenges for survivors, depending on their identity and their orientation, depending on gender roles and stereotypes and sexual roles and stereotypes. So for women, for example, this might reinforce the belief that women should be passive, vulnerable, weak. This idea of if you say something, you know, that means that you can't handle things, and how this might conflict with the image of what an ideal, quote unquote, ideal soldier is. And so many women might respond to experiences of MST with passivity, with numbing, with self-blame, to continue to combat that gender stereotype, that women might be vulnerable, passive, and weak. For men, it's what's interesting is that it can be incongruent with kind of the expectations, the westernized, traditional expectations of men, that men are strong and aggressive and dominant. And so this sort of thing doesn't happen to a man. If a man is assaulted by another man, right, that might bring into question for the individual their own sexual orientation, their own sexual preferences, and not in a way of, oh, does this change what your sexual orientation is, but how does this kind of bring up challenges or bring things into question? How does this kind of impact how you view your own sexual identity? And oftentimes men might respond to this with aggression. There's also increased stigma, and this stigma will really limit kind of one's desire to seek help or to disclose. So if you feel really stigmatized by after your experience of MST, it's going to limit how likely you are to seek help, for sure. Okay, so in terms of this, we also want to talk about sexual minorities, right? The LGBTQIA+ community, who actually experience higher rates of MST. And sometimes this can be because of their sexual orientation or their sexual identity. Just kind of wanted to bring up this idea of the don't ask, don't tell policy, which was thankfully repealed in 2011, but individuals still experience, especially individuals that identify as transgender, still experience extensive discrimination, and military sexual trauma is one method that has been used to perpetrate hate crimes against this group of individuals, as unfortunate as that really is. So I wanted to just kind of show this a bit about how the military culture and interpersonal trauma, which is trauma that occurs between one individual and at least one other, so between people, how MST kind of comes to the middle of that and how it kind of ingratiates both of that, right? So within the military culture, right, which is a very team-oriented, group-oriented kind of mindset, interpersonal trauma really can kind of bring that to a head, because the very people, and these are things that veterans have told me, but the very people that we're supposed to depend on for our lives, that we sleep next to, that we that help us, that help train us, the very people that we depend on for everything might be the people that harm us, or might be the people we can't tell about being harmed because they wouldn't believe us, or for a variety of reasons. And so when these two things intercede, when these two kind of things combine, it can make it more difficult for an individual to feel able to get support, let alone report it. They might blame themselves or really worry about how this might impact their career, which, you know, is unfortunately not totally irrational, because it is not uncommon for veterans who have survived sexual trauma to their career to have been impacted negatively because of it. So it's not a completely, out of the realm possibility, which kind of continues this cycle. Um, Two other big things that I really just kind of want to hit on are this idea of perceived rejection from their family within the military, from their unit, in terms of rejection in potentially felt ability to complete their job and be part of the team, but also this idea of institutional betrayal. I'm not sure to what extent participants kind of know what institutional betrayal is. And so for those that don't, institutional betrayal is this idea that, that you feel betrayed not only by the people around you, but almost by the institution, the system, the society at large. So examples of institutional betrayal might be not going to the VA because when you tried to report your military sexual trauma, your leadership kind of told you that nothing would happen anyways, or, suck it up, or it's not that big of a deal. And so then feeling betrayed by the people you depended on by leadership, and then seeing other systems that represent that. So other government systems, because right, the military, the government, the VA can be all interconnected for veterans, can kind of continue this cycle of felt betrayal. So let's talk a little bit about some interpersonal trauma triggers. So it seems that, it can be easier to conceptualize or understand a combat veteran, right, that might have a strong reaction to someone sneaking up on them or standing behind them. But we might not recognize that the same kind of reaction can be seen for individuals that have experienced military sexual trauma. And so some triggers for individuals that have experienced sexual violence or military sexual trauma might be this invasion of personal space. It might have to do with, they might be triggered by if their movement is restricted in any sort of way, if their boundaries or they're vocalizing their needs or trying to advocate for themselves and it's not being respected or it's being minimized. These things are going to potentially be triggering. Interacting with institutions, as kind of the example that I just utilized, would be another example. Even encountering individuals that might look, sound, or even remotely resemble their perpetrator. And that could be specific phenotypes, right? But it also might be someone like in a leadership role. So if their perpetrator was someone in a leadership position, then anyone potentially that they interact with in a leadership position might trigger these kind of responses. So that's kind of where the authority figures also come in. So let's see. I'm going to briefly touch on spirituality, moral injury, and MST. And the reason I say briefly is because Chaps, who is another wonderful staff member of the Road Home, did an impeccable, if you haven't seen it, an impeccable training on spirituality, moral injury, and veterans. So I'm going to touch on this, but if you have time, I would definitely encourage you to review that training as well. Moral injury, for those that don't know, is this idea that sometimes we are in the military, sometimes we are asked to do things that go against our values, our ethics, our moral code. But in the moment, we potentially engage in those behaviors because we're being asked to by authority figures or because it makes the difference between living and dying. So for example, harming another individual might not be something that we would do in everyday life, but in the military, sometimes that's the way to stay alive. And so sometimes it might be about engaging in behaviors that kind of go against our moral code, but it also might be bearing witness to acts that feel immoral, or feeling unable to be able to stop those kind of acts. So all of these kind of things can kind of instill this idea of moral injury, and that definitely can be experienced, especially related to MST, because if, for example, if there's this ethical belief, for example, that your trainers, your leadership, your teachers, for example, are supposed to encourage you, not harm you, and then you're harmed by them, it not only betrays what you know as kind of morally and ethically right, but also kind of your ability to be able to do something about it, especially within the context of war. So I'm gonna push through this. Okay, so this is the part I think I really want to focus on as it relates to today, because oftentimes with trainings about military sexual trauma, it's kind of what it is and kind of how can mental health professionals be of assistance? What are the statistics? What are the treatment? And less often, it's how do we apply our knowledge of this information to other fields where providers will interact with survivors of sexual violence. So the first thing I kind of want to recognize are the effects of MST on the survivors, right? So there are mental health, medical, and kind of adjustment related concerns. The biggest thing to note, if you take nothing else away from today's presentation, is that military sexual trauma is not PTSD. Military sexual trauma or sexual violence is an event. It is a trauma. It is an experience or a series of experiences that somebody goes through, but that in and of itself is not a diagnosis. Yes, individuals with military sexual trauma might go on to develop PTSD, but they also might not. And there's a whole health of mental health. There's a whole host of mental health concerns that an individual that's experienced MST might notice. There might be depression, suicidal ideation or suicide attempts, self-harming behaviors, substance use, anxiety or eating disorders, dissociative disorders, somatization disorders, even personality disorders. In terms of medical conditions, there's been a lot of research kind of recognizing the impact of sexual violence on kind of physical health. And we're noticing liver disease, chronic pulmonary diseases, chronic pain, gastrointestinal issues, gynecological issues. In men, there are higher incidence of AIDS. In women, there are higher incidence of obesity, weight loss, or hypothyroidism. We're also noticing adjustment-related issues. So in addition to kind of this increased likelihood for suicidal ideation or suicide attempts, we're also noticing impaired social functioning, impaired occupational functioning, risky health behaviors, experiences of re-victimization, which is 1 in 3, or 1 in 3, homelessness, even intimacy and sex-related issues. And if these things aren't asked or explicitly talked about, then we might never know, and they might never receive the help if they don't feel necessarily comfortable bringing it up. And that's kind of where we come in. So another thing I want to kind of touch on are what are some of the reactions that a survivor with military sexual trauma, or again, a survivor of sexual violence, what kind of reactions might we notice in the room during an appointment, during a routine, physical or checkup or dental cleaning? So they might appear highly anxious, agitated, or jumpy. They might appear tearful during exams, but no obvious cause. They might physically withdraw or become very quiet or frozen. They might have difficulty concentrating on what you're saying. They might be very distractible or seem disoriented. They might also minimize symptoms that might require a more intrusive exam. So for example, for a gynecological exam, right, if you're minimizing any pelvic floor related issues, if you're minimizing menstruation related problems, right, then that kind of limits the provider's potential need for a pap smear or a more invasive gynecological exam. You might also notice that survivors of sexual violence might cancel appointments or refuse needed care. They might exhibit strong emotional reactions to relatively benign interactions. So even you scooting your chair up a half inch. They might also experience flashbacks or dissociate during appointments. So there are some aspects of appointments that might, or interactions with other people, especially during medical appointments, for example, that might be particularly stressful and distressing for military sexual assault survivors. So this might mean being touched, even accidentally, being touched, having someone stand behind them, having someone lean over them, procedures that might require physical restraint or confinement or sedation, right? Because these are all things that might invade their personal felt space and might invade their felt control over a situation. Because at the very core of it, military sexual trauma, sexual violence is this idea that an individual's control, their power is taken away from them in a moment or in several moments or over several periods of time. And so there are situations where we might be perpetuating that felt lack of power and not even intentionally realize it. So other exams or procedures that might be particularly distressing for this population might be pelvic exams and pap smears, pap tests, breast exams and mammograms, dental exams, rectal exams and colonoscopies, urology exams, endoscopic or other invasive procedures, even fundoscopic exams. And I hope I said that right, because I'm not even 100% sure about that. So other potentially triggering situations for survivors of military sexual trauma might even be outside of the office. It might even be aspects of the medical center environment itself. If it's crowded, if it's noisy, if there are open areas, where anyone can enter or exit at a moment's notice and they can't necessarily be on alert to all of their surroundings. As I said before, right, coming to the VA or the hospital might remind veterans of their military service, of their trauma, or even the consequences of it, which might bring up difficult memories. I've worked with survivors of military sexual trauma who had to be hospitalized after these events. So even being in the hospital again was triggering for them. And so even medical procedures, as we're kind of talking about, can kind of bring up this distressing experience for them, especially because of the patient-provider relationship, which inherently resembles aspects of this power differential as a victim-perpetrator relationship can. So again, it's all about this felt lack of control. So kind of jumping off of that, right, why might my patient react this way? There's a whole host of things that, might trigger them. Why might this be happening? So it might have to do with this power differential, this inherent power differential between yourself and the patient, potentially feeling exposed and intimate body parts being touched. Even if it's rolling up your sleeve to get blood work done. It doesn't even have to necessarily be something related to like the sexual organs. It's really more about feeling a lack of control over the situation or potentially being in physical pain. And so, and the last one that is a bit harder to kind of of course, recognize, but important to have kind of transparent, open conversation about would be that some exams and procedures might recreate some of the physical sensations that a veteran experiences at the time of their sexual trauma. So let's talk a bit about like, okay, great, we've heard all of this, like, yikes, no one's intending to, you know, be anything other than respectful, moral, ethical, and trauma sensitive. So what does that actually look like? So here are 6 core principles of a trauma-informed culture and trauma-sensitive care, right? This idea of ensuring this physical and emotional safety of our patients, kind of doing what we can to kind of maximize trust and kind of building that rapport, really empowering them to not only make their own choices or collaborate in kind of the decision-making process, but also to identify their own strengths and to be able to identify their own strengths and help them figure out how they can calm themselves down, for example, during a dental exam that's particularly distressing. So one aspect in terms of enhancing trauma-sensitive care has to do with certain interdisciplinary strategies that we can incorporate. Coordination of care is not only key among patients, but especially with survivors of sexual trauma. Coordinating care, good communication between providers in of multidisciplinary fields is going to be really important so that providers are on the same page. Maybe as a psychologist, right, I know some triggers that my veteran and I have talked about, but maybe as their gynecologist, for example, or their urologist, you might not recognize those triggers. Maybe I know my veteran specifically likes to be sat right next to the door because it helps them feel safe. And if we can coordinate care, if we can kind of create that strong communication and partnership, then that's something I can help you to know. And together we can kind of work to create a comfortable, safe space for the veteran or for the survivor. Also really important to consult with other team members, either on your team or across different teams, about the specific needs of the veterans and about MST in general. Also want to create opportunities for warm handoffs to behavioral health staff so that they can help the veteran address mental health specific needs and provide additional support to medical providers as is feasible. So another kind of way that we can enhance trauma-sensitive care is by expressing support and that empathy. Having that warm, kind of patient, supportive tone and affect. Being aware of our own bodies, our own body language. What is our body language saying when we are behind a desk and a computer is in our face versus sitting, looking at the patient. I mean, of course, having clipboard or whatever you need, but you want to be sure that you're communicating, that you're paying attention and that you're listening and you're ready to help. Because both verbal and nonverbal behavior matters. It's tougher. I know sometimes these things happen, right? But it's tougher to maintain eye contact if there's a computer screen between you and them. So making eye contact, speaking in a calm, quiet, unrushed tone, these things can create that environment of safety and kind of show that you are there for them, right? So don't appear too busy to listen, right? Rushing in, rushing out to the best of your ability, right? Talking loudly, quick bursts, making kind of blanket statements without providing additional explanations. All these things can kind of feel dismissive to veterans, but also survivors of sexual violence. It's really important to collaborate with this population, letting them know what they can expect, the rationale for it, and kind of what each moment is going to look like. Because predictability for them can help enhance a felt sense of self-agency, but also power and control. So we also want to help figure out whether there are ways we can reduce the power differential, right? So this is where that collaborative process comes in, giving options, discussing choices whenever there are possible, being transparent and explaining reasons for why we might choose or suggest a certain course of action versus another, asking permission before moving closer to a patient or before touching. I even ask permission if it's, I ask permission before I close the door to the office. And I do therapy, so we both know that the door is going to have to be closed. However, at the end of the day, if they want it open, then we're going to do that because we want them to feel comfortable. I've even asked patients, you know, where my seat is compared to theirs, you know, do you feel like I'm too close? Would you like me to back up? Is this an okay distance? So these are all little things that can really convey that you care, you are there to listen and to help in ways that are just little for us and kind of, but mean a lot. Periodically asking how they're doing, sitting at the same level as the patient, right? Nobody likes when someone's standing over you, right? And so being able to sit at the same level as the patient, preferably without a desk in front of you, can also increase that felt comfort and reduce that potential power differential. So sometimes, and I'm not sure the extent to which any of you guys have experienced this, but sometimes medical providers are the first individual that a survivor of sexual violence discloses their assault to. It's actually more common than we think, especially like primary care providers, because they're often the first line of defense for a lot of like the medical and mental health kind of world. They're the gateway in a lot of ways. So you might be the first person that they disclose to. So what do? The first thing is really to establish a comfortable environment, right? Some of the things that we've talked about, being aware of what your behavior is and what your body language is conveying. And then also responding empathically to that disclosure, right? Providing that validation, that empathy, discussing how this might impact their treatment needs and normalizing this. So sometimes we need to adapt, right? So sometimes despite our best preparations, there are going to be times when our veterans or our patients have strong reactions to our interactions with them or to exam procedure, no matter how trauma sensitive or trauma informed we are, right? Maybe sometimes we try to skip over something or push through something because we are concerned it might be distressing. We want to relieve that distress. And instead they become upset or more distressed. And so if that happens, if possible, just pause for a second, just stop. If it makes sense, if it doesn't, understandable. But if it does make sense, just pause. If it's not possible, kind of explain why it's not possible. But the important thing to do is that we want to act in a way that communicates and conveys our empathy and our concern about how they're reacting. And so asking how they're doing, what is happening, and what we can do to help is going to be extremely effective in developing that rapport, maintaining it, and normalizing those responses. So I also have a couple other ways to kind of reduce patient distress in general. So as we said, kind of other ways that we can reduce the power differential, asking patients if there are changes to the environment that might be more helpful, right? As I had said, leaving the door slightly ajar, letting the veteran or the veteran kind of moving their seat closer to the door, having another individual kind of attend the session, as long as COVID precautions are, of course, being maintained. When veterans kind of have a reaction to exams, to procedures, right, there's a couple different ways that we can go about assisting them. Anticipate and prepare, right? Talk to them ahead of time about what might happen and brainstorming ways to help them cope, or encouraging them to discuss this with their behavioral therapist or their mental health provider. In doing things to ensure that the patient feels in control, asking them permission, letting them know that you'll stop if they ask, respecting their reactions, right? Not ignoring them or minimizing them. If someone has a strong reaction to something, we want to make sure, again, that we're really listening empathically to what they're saying. If it's appropriate, apologize. If it's not appropriate, then don't. But the main sentiment of what I'm saying and what I'm trying to convey is this idea of we're listening, we're here, and we will go at your pace to the extent that it is reasonable and appropriate. So I know we only have a couple minutes. Does anyone have any questions or things I can clarify?
I want to give other people the chance to ask before I. Does anyone want to go first?
I could ask a question. I'm not sure how much you know about this. So I'm going to be, hopefully, an ED emergency med provider.
Great.
So I know that there's sane and safe nurses in like, usually in TRICARE hospitals. Actually, I'm not positive. I've seen it on a Facebook page, so maybe. But like, how would you recommend going about if somebody's coming in for like their primary encounter is like sexual trauma?
Yeah, so that would be where I would definitely go back to kind of the slides about disclosure, about really coming from a place of normalizing that experience for them, giving them that space and making sure not to rush them, but also helping them recognize that if you're not going to be their permanent provider, you're just doing triage, for example, that you welcome them disclosing, but they might feel more comfortable, providing this information, these specifics in more depth to the person they're going to be working with.
Yeah, sorry. I meant more like if they're coming in because they were sexually assaulted.
Okay. So help me understand how I can be helpful.
I might have to go more towards like sane and safe. I think that's what ends up happening. Yeah. Okay. Just like it just happened and now they're coming to the emergency department, and you as an emergency provider are a mandatory are you a mandatory reporter? Pretty sure you are. Yeah.
Okay. Any other questions or things I can clarify?
So I had two comments, but not a specific question.
That's okay.
So one of my comments was, it was really interesting. I mean, there's a wide range of how people react or internalize, I guess, what's going on, what has happened to them or what's happening to them. But a lot of what you described sounded like learned helplessness, which I thought was really interesting. And the other thing I wanted to comment, just because I don't think it was mentioned, but MST, I've talked to some people who said that from my volunteering that their MST was caused by a significant other or spouse, ex-spouse. So I just wanted to bring that up because I don't think I saw it on one of the lists.
Yeah, so it's not uncommon for perpetrators of sexual violence to be someone we know. And in the military, there's a potentially greater chance of that, right? Because if you're living and sleeping with your squad, right, or with your unit, that might be more likely. As it relates to it being your spouse or partner, I don't have actually the statistics on that as it relates to military sexual trauma. I will say anecdotally, I would say anecdotally, it would, for the veterans that have talked to me about experiencing military sexual trauma as it relates to a spouse, it would also, we also considered it interpersonal violence. like domestic violence. But yeah, the domestic violence and sexual assault or military sexual trauma often co-occur more than we would like. I do want to be mindful of time. It's 1 o'clock. But if anyone has any questions or comments or needs any resources, I'm more than happy to provide them. My email is at the link on the first slide, and you guys are more than welcome to have these slides. But yeah, I appreciate you guys taking your lunch hour to spend with me. And yeah, thank you.
Thank you, Dr. Kressler. I know this is an incredibly difficult topic, but so important to talk about. So thank you so much for putting this on.
Yeah, absolutely.
Thanks so much.
Thank you very much. Thank you.